Thank you, Dr. Jackson, Dr. Herron. This is my number one obligation to give this talk. I'm really privileged to give this presentation. Let's start with slippages after banding. We need to understand that we are dealing with a patient population where problems with the hiatus, problems with the esophagus are very prevalent. If you look at the prevalence of gastroesophageal reflux disease, it's 5% in the general population, 31 in the obese, and goes up to 36 in the morbidly obese. And this patient population has a high prevalence of other abnormalities, as hiatal hernias. They have increased intra-abdominal pressure. A lot of these patients have diabetic gastroparesis. And this is an issue when you talk about a patient with banding vomiting. Vomiting is not always a slippage. We need to understand why they're vomiting. Many of them have also decreased esophageal clearance. They have dietary abnormalities because of the band that doesn't allow them to have protein meals. So all this creates a special situation in which patients will present to you either with gastroesophageal reflux disease or vomiting. And the problem has been very well documented in the literature about what this reflux and vomiting might result in up to 31% of patients that undergo bariatric surgery developing reflux esophagitis. Not a long time ago, we published in Surgical Endoscopy a series of 100 bariatric patients that came to our institution thinking that they're going to have a gastric banding or bypass. We did manometry studies, and it's interesting to see that a very significant amount of those, 41%, had abnormalities in the manometric studies. And interesting to see is 100% of them were asymptomatic. So we need to be very careful when we put bands on these patients. And again, we need to be very careful interpreting their nausea, vomiting, and gastroesophageal reflux disease. And I assume or hope that most of you that are sitting here in the audience are not bariatric surgeons. So let's not wait for them to vomit. If a patient comes to you and is complaining about gastroesophageal reflux disease alone, abnormal heartburn, and had a banding, your suspicion should be slippage, erosion, but you should also suspect that probably that patient did not need a band. And the first thing we need to do in this patient is to rule out that they don't have poor motility, hiatal hernia, do an endoscopy, and do an upper GI series. Again, one of the problems with bands when they get over-adjusted is that these patients will develop megaesophagus. They start collecting food in their esophagus, and that triggers them to be vomiting and triggers them also to have reflux. It could be that they have megaesophagus because of achalasia. We've seen that in 1 out of 100 patients, but it also could be that they've been over-adjusted, or it could be that they have a slippage. So let's not take this so lightly. It's not just to give them PPI and send them home. We need to study these patients. And this is how it looks like when these patients are over-adjusted. This is how it looks like when you got a megaesophagus. This is a terminal stage of megaesophagus, and this is to some degree an emergency because this patient might be vomiting, might not, but might be aspirating. And I've seen patients after over-adjusted bands or slip bands that ended up in an ICU on a ventilator due to aspiration pneumonia. So we need to take this seriously. The band needs to be immediately opened, and if the patient does not have immediate improvement, recovery from this x-ray, that band needs to be removed. If the band gets deflated and the patient, you see that there is a better passage of contrast material into the distal stomach, you can wait up to 8 weeks, bring them back, see what happens with that esophagus. If you see that there is recovery, you can slowly start readjusting them again, but really very slowly. The other problem is the slippage, and depending on whom you read, can go from 1 to 9%. And slippage will result, again, in reflux, vomiting, food intolerance. And obviously, the way to do a diagnosis of slippage is to do an upper GI series. Why do these bands slip? It could be because the patient is vomiting all the time, poor dietary habits. It could also be that it was not properly placed. There are different types of slippages. Here you can see very clearly the AS, talking about an anterior slippage, and the stomach becomes horizontal. And then you have the posterior slippage, when the stomach, the band becomes horizontal. So there are two ways to see it again. Here you can see how the stomach becomes horizontal, and here you see how the band becomes horizontal. And this is important for us as bariatric surgeons because it can tell you exactly how to fix this and if it's fixable or not. So what do we do with a slippage in a patient that comes without a fever, without pain, without leukocytosis, A slipped band is not a happy band, and a patient with a slipped band should not be a happy patient. So the first thing you need to do is to deflate that band. This can become an emergency. This can end up in the stomach being strangulated and a major, major surgical procedure. So the first thing you need to do, this patient needs to go to the endosuite and that band needs to be deflated. Now, again, if you deflate that band, you can wait again. There are studies being published where you say, okay, you wait again 4, 5, 6 weeks, you bring the patient back, and you can see that that slippage has improved or it's even gone. So you might adjust it a little bit, and if you see that this doesn't get better, then you need to proceed. And yes?
How do you deflate a band?
You guys know how to deflate a band? If not, send them to the x-ray. It's a port. They will go with a little needle, with a special needle they have into that port, and they will deflate that band. That's the way to do it. But if you don't deflate that band immediately, this might erode, and erosions can become also acute. Not all erosions are chronic erosions, as you can see here. This is a band that eroded over, I would say, months, if not years, and that's how it looks like in the x-ray, which is pretty dramatic. And erosion can become acute too. The patient will develop fever, pain, leukocytosis. This is an absolute surgical emergency, and not only you need to deflate that band, but that patient needs to go to the OR, and you need to remove that band. So a slip band, a silent band, needs to be deflated, and it can be observed, but if it's symptomatic, it has to be removed. So we get into the strictures after gastric bypass, and we need to remember also that strictures can be acute or can be chronic. Specifically, the acute one is important to you when your bariatric surgeon has done a bypass and left town, and because they can manifest hours after surgery, and they are mainly errors in judgment, errors in technique. And the point here is that the patient is belching and having sialorrhea. A patient that is 2 days after a gastric bypass that is belching and spitting saliva is a patient that is aspirating. And this is not one of those strictures that you put on PPI and send home. This is a patient that needs immediate care, because they are at risk of aspiration, as mentioned before. So these are patients that you can either take back to the operating room, do an endoscopy, under laparoscopic surveillance, and I'm not suggesting you should reoperate on those, but at some point you might have to. You can put an NG tube to make sure they don't aspirate. The most common of these strictures, however, are the chronic ones, the ones that are going to manifest weeks or months after the surgery. The reason is multifactorial, and they manifest with pain and vomiting, and food intolerance, specifically with solid food. Strictures are usually related to, I would say, ulcers in this patient population, and the reasons why they develop ulcers can be multifactorial. Here you can see emergency room admissions, non-specific diagnosis. I'm sorry it's not projecting very well, it's supposed to be in white color, but you can see that stomach ulcers are a significant amount of those, and obstruction of the anastomosis represent probably 50% of emergency room readmissions. The same thing here. So 30% of patients that are coming to the emergency room have problems with gastrointestinal anastomosis and with their pouches, and this is significant. In our experience, patients after gastric bypass have a stricture rate of 6.6%. And the problem here is that you need to understand that the bariatric surgeon is trying to do, and this is the only situation in surgery where you try to do an anastomosis as small as possible. If it is too small, you might end up with a stricture, sialorrhea. If it is too large, that patient will, in the long term, fail to lose weight or have weight regain. So this is important that you understand why do we have strictures in bariatric surgery. It's not that we want to have them, but if you don't have strictures, if you have a bariatric surgeon that never has a stricture, probably his or her patient population in the long term is going to fail to lose weight or is going to have weight regain. So if we look at what are the criteria to create a good anastomosis, they have to be not more than 2.5 centimeters in size. It is important you have a small pouch. The problem is that a lot of bariatric surgeons leave behind huge pouches. And if you have a large pouch, what you got there, a lot of parietal cells producing acid, and they are going to create a stricture. Reasons why we have strictures: surgical technique, tension, ischemia. As I mentioned to you, the size of the pouch, patients taking a lot of aspirin, NSAIDs. It could be also related to gastrogastric fistulas. And in this drawing, this scheme I'm going to show there with a pointer, usually the stomach is separated from the pouch and the alimentary limb. And this should create hypogastrinemia because the pH goes down. The moment that you open the door and food goes from the pouch into the gastric remnant, it will start creating hypergastrinemia. Acid gets produced, goes through that new door, through this fistula tract into the pouch, burns an ulcer, burns a stricture, and this is a patient that's going to start creating problems, nausea, vomiting, pain. And over time, they're going to start regain weight because food is going to go the natural way. They're going to lose the dumping syndrome that is protective to some degree. So it's very important to understand that gastrogastric fistula could be the reason for a stricture or for an ulcer in this patient population. They get manifested with persistent vomiting, dysphagia, and regurgitation of saliva. The diagnostic algorithm should be clinical signs and symptoms, radiography, and obviously in that case we do an upper GI, barium swallow, and endoscopic surveillance. They become symptomatic when those anastomoses become smaller than 10 millimeters or 1 centimeter. That's when these patients start having trouble. How should you treat them? If your bariatric surgeon is not in town, if you have a good GI guy, you send them for an endoscopy and they can dilate them. They have to be very careful how they dilate them. That has to be done, the TTS system, which is through the scope, and we usually do that ourselves with a balloon. You can see here our series of 61 patients with strictures. Time from surgery to diagnosis, 20 to 154 days. Dilatations per patient, 1 to 5. We had 3 perforations, and this is something that can happen to you as a general surgeon, that the patient comes to the emergency room after it's been dilated somewhere else by a gastroenterologist and has a perforated ulcer. No major surgery. And I tell that to my residents, to the fellows, in the emergency, the smallest procedure. You get in, you put drains, you wash out, and you get the hell out there. There is no reason to reverse the bypass, to redo the anastomosis, to do a major operation, remove a gastrogastric fistula, drainage, drainage, and drainage. And that's all you need to do, and these patients are going to do great because this is a fistula of saliva and air. Put them on antibiotics, drain them, and they do very nice. You can see 128 dilatations, the dilatation up to 80 millimeters. Every time we went up above 50 millimeters of dilatation, that's when they perforate. So pay attention to that as well. Here you can see the stricture rate, 61 patients, 28% had a single dilatation, 33 had 2, 26% had 3. Very few of those required more than 3 dilatations. They really do much better after 3 dilatations, but stricture is a problem. The 3 perforations that we found, they all had free air in the KUB, they all had laparoscopy and drainage. In all of them, we passed the 13.5 millimeters of balloon, and there were no predictors, there were no predictors that we could find to say why did they perforate. How often do you need to reoperate these strictures? And I'm sure if you're not a bariatric surgeon, you're not intending to do this, but just for you to understand, it's extremely rare. From 154 patients with anastomotic strictures, only 10 patients needed to be revised and reoperated, which is 0.4%. All had at least 4 dilatations or more. The diameter was always less than 10. They were all revised laparoscopically. They stayed in the hospital on average 7 days. Reoperative surgery pays a price, as you will see in a second. Morbidity, 30%. So don't try to do your bariatric surgeon a favor and resect those strictures. Drain them if they perforate, watch them, dilate them if not, and send them back to the bariatric surgeon. And look at this. In our institution, with over 5,000 bariatric surgeons, we lost 1 life in primary procedures. When we talk about reoperative surgery, it goes dramatically. In this patient population, we had 1 death in 10 patients that came with reoperations. The technique, we're going to get too much into that, but the anastomotic stricture, it is something that is going to be happening to bariatric patients. You're going to see them in the emergency room. They're going to be coming to your practices, so you need to be prepared to treat them. Endoscopic dilatation is safe, highly successful, and is a treatment modality of choice. Revisions are rare. It can be done laparoscopically, but they have a higher morbidity and a higher mortality. And I think I'm going to stop here so we can ask in the next 5 minutes some questions. Thank you very much.
Thank you.
Hi, nice talk. Joe Dodd, Nevada, Missouri.
Have you guys used steroid injection part of the dilatations like we do in esophageal strictures to reduce your risk of recurrent stricture?
Well, before we started doing our own endoscopies, the gastroenterologist did it twice, despite me being against that. I don't think that, in my personal opinion, that steroids are very helpful. They did it twice. These patients did fine, but I'm not sure that it was because of the steroids. As I showed you before, we will know that the great majority of dilatations are going to do fine with or without steroids. We didn't see in our practice the need to do that.
Bernie Kempker, Jasper, Indiana. Sort of thing I'd get called for in a small town about midnight would be, say, a food bolus obstruction, and then I come in to do the endoscopy, and they go, oh, by the way, there's a band in place. And I don't know how to deflate the balloon. Our radiologists go home at 8 o'clock, don't come back till 8 in the morning. We get our films read by Australian radiologists at night.
Can you I have an echo here. Can you?
Okay, so I guess the question is, a patient comes in with a food impaction, you get called to the ER, you talk to the patient and find out, hey, this person has a band in place.
Band in place. I can't get a radiologic deflation of the cuff.
Well,
So how do I deal with that?
it is a relatively simple, I would say,
do I need
technique to deflate that band. If you cannot do it, your radiologist can do it. It is a port technique. You just need to, to manipulate that port and do it. You can do it with a regular needle or a spine tap needle if you don't have the right needle for those ports, but it's doable. Certainly, you can give this patient, if he's going to stay in the hospital and observe them, you can give them Coca-Cola. I have disclosures, no conflict of interest with that company. And that's what we use for the BZORs. Sometimes these are BZORs. But I think just by opening the band where your radiologist can do that, they should do much better.
Yeah. So generally what we would do at Mount Sinai, I guess, our radiologists are not as available or cooperative as yours, but we generally do the band fluid adjustments ourselves. Typically, the ports are superficial enough that you can palpate them, almost like a chemotherapy port or something like that. Usually, it's somewhere on the abdominal wall. If you ask the patient, they'll say, "Yeah, my access port is right here." If you can usually feel the port, and you can access it. Now, in a perfect world, you should access it with one of those special non-coring Huber needles, like you use for a chemotherapy port. If it's 3 in the morning and the patient's vomiting and can't swallow their own saliva, just get a 23 or 25 gauge needle, palpate the port, and go right through the middle of it, and you'll kind of feel the needle going into the rubber diaphragm there, and just suck out as much fluid as you can. And you'll be amazed that a lot of the time that's going to just give them complete resolution of their symptoms.
Thank you.
One other thing I might add, and I think there's a million things you can mention here, but if you've had a patient who's been vomiting for a while, always think about acute thiamine deficiency, which can give irreversible neurologic damage, Wernicke's encephalopathy. So it's easy to give a vitamin B1 injection to someone who's been, who presents to the emergency room after throwing up for a week.
Keith Applegren, Pittsburgh. I haven't had this complication, but I hope I never see it. A slipped band with a prolapsed proximal stomach that necroses. So you see that on CAT scan, you got free air. I guess I know I have to resect that stomach, but do I put a bougie, I take out the band, do I put a bougie in to be sure I don't narrow that? How do you handle that perforation of that segment that's prolapsed?
Well, I don't know if you want to answer first, but you want to answer first? What we would do in a patient like that is take them to the operating room, obviously, start laparoscopically. You deflate that band and you see if that stomach recovers. We've seen it, that stomach recovered, that you don't necessarily have to rush them to an operating room. But if you tell me that you go there and the stomach is black, and the patient has fever, leukocytosis, and free air, and it's a perforation, you have to do a resection. You have to do a resection, and then you have two options as a general surgeon, either to divert, put a gastrostomy, put an esophagostomy that can be diverted internally. I won't go to the neck. I think that is kind of Frankenstein. We shouldn't do that now. And you should have an experienced gastrointestinal surgeon give you a hand then to reconnect that. This is approach A. If you feel like doing it, you do a Roux-en-Y limb, and you should reach without any problems to do a lateral esophagojejunostomy. But I won't try to recommend to everybody to go there and resect that. Number one, they're very rare. Number two, they do recover by themselves if you open that band. And number three, you always have the option to divert, and refer the patient to another center for a final approach if you don't feel comfortable.
Yeah, again, I think that's a pretty scary but an unusual situation, and 98% of the time you're going to take the fluid out of the band and they're going to feel all better and say, you know, thank you, doctor, I'll follow up with my bariatric surgeon, and that's the end of that. In particular, the foods which are going to be an issue, you know, a common story you hear is that a patient ate a hot dog or a sausage or something with like a casing on it, which can easily plug up the small outlet in a gastric pouch. And again, often deflating the band is all you need to do. Any other questions for Dr. Rosenthal?
Thank you very much again.
All right,
Thank
thank you,
you.
Raul.